Thanks for joining us for today's webinar, Starting Out in Skin Cancer Work. My name's Hamish Elton. I'm the host for today. I work with HealthCert Education. The presenter today, I think most of you may be familiar with, is Paul Elmsley. Paul's the CEO and founder of both HealthCert and National Skin Cancer Centres. Today, Paul will be sharing his experience in setting up and running a successful skin cancer practice within your general practice or as a standalone clinic. This will give you insight on practice setup, tools required, and other essentials you need to know. Questions can be submitted in the GoToWebinar panel, which should be up on your screen. You'll see a little arrow next to the word questions. If you click on that, you'll have an area where you can type in questions. We'll gather those questions during Paul's presentation, and then I'll go through and we'll run through and get Paul to answer them at the end. There'll be plenty of time for questions, so just type them as they come to mind. The webinar will also be recorded, and you'll receive a recording of this in case you miss any of it, and you're also welcome to share that with any colleagues who may not have been able to join today. So without any further ado, I'll get started and introduce Paul and get you up and running. Welcome, Paul.
Thank you, Hamish, and thank you everybody who's taken time out of their very busy lives to spend it with me this afternoon. It's a great pleasure. Once again, I get to present on a topic which I'm very passionate about, which is around obviously helping particularly primary care doctors, generalist GPs, being able to set up a skin cancer service inside their practice. I think that, knowing that, 2/3 of Australians will be diagnosed with skin cancer in their lifetime, and also the fact that 80% of all cancer in Australia in a given year is skin cancer, being able to set up and operate an effective skin cancer service is really it's actually a foundation skill or service that you need to be able to provide inside your general practice. So what I'm going to be doing, I've been building and setting up and running skin cancer services for almost 20 years now. God, it feels that long. Probably why I've got my grey hair, but I think the key thing for me is I'm going to share my experiences around that. But the other thing to note, besides, I suppose, my experience in the education side of it, is that we have set up 25 practices of our own, and we actually still operate 9 medical centres. So we are conscious of, the knowledge I'm sharing is not someone who's, from an academic perspective. It's from somebody who works in the field on a daily basis. And these are the learnings that I've had over time. I'm obviously going to show you a very high level introduction to, once again, these sorts of services, but just to give you the key elements, which I think are critically important for the success of going forward. So once again, we're going to be focusing on the essentials and setting up and running a skin cancer service inside a primary care clinic. As Hamish mentioned, it equally applies to whether you're in a general practice, as a family practice, or you're looking to set up a skin cancer service, which is a sort of a sub-practice or otherwise. I mean, the principles are basically exactly the same, just basically the building it's being delivered out of might be a little bit different. So the essential elements, in my opinion, are how you set up your consulting room so we can optimize that, and that's around focusing on how we can set up a room to optimize your productivity. We want to make sure, I think the key thing as a doctor, what you're doing is you're selling or making available to your patients your time. I mean, that's what basically you do. I mean, also your knowledge. I'm not totally disregarding the knowledge, but most importantly, it's your time. So we want to be in a position that when you're setting up and operating in any particular environment, but obviously today we're talking about skin cancer, we want to optimize your productivity, because if you can be able to get rid of the wastage and the time wastage in what you're doing, it allows you then to see more patients and then hopefully, conduct more skin checks and save more lives. And also it's just the best use of your time. The second one is having all the right tools in the right place. So one is how your room's set up to optimize your productivity and workflow. And the other thing is, of course, is that you need some of the, we need some essential tools. And I think in skin cancer, thankfully, there's only a few of them, but you do need to have them, and they need to be in the right place. The other element is setting up your appointment book. And I'll go into that in a little bit more detail in a minute, but skin cancer is a unique opportunity for you to be able to set up your appointment book a little bit differently from standard general practice, which will help you, once again, in having the time you would like to spend with your patients to be able to serve them the best. And then I want to talk about the services you should be able to provide. So I think that, as a doctor in Australia, with, once again, skin cancer incidence as high as it is, there are certain things you should be able to do. And if you don't perhaps have those skills, you need to look to obtain them. And the final element, of course, is we want to be seeing the right sort of patients. I mean, the fact of the matter is there is a segment of the populace who are at high risk of skin cancer, and they're the ones that we would like to obviously encourage to get their skin checked. So setting up your consulting room. The number one thing that you need to do is to make sure you have good lighting in your room. I mean, the fact of the matter is if you can't see the skin or can't see it very well, it's very hard to do this in the very first place. So one thing I help teach people or get them to understand is that most medical practices have fluoro tubes in the roof, right? And those fluoro tubes are what they call a warm white. So it's a bit more of a browny white sort of color, which are not very good for looking at the skin. And in fact, what you should be doing is looking to take those fluoro tubes out and swap them out with what they call daylight fluoros. Now, these things are able to be bought from an electrical shop. They're cheap, you know, they're sort of $30 for a tube. And once you swap those out, it'll change your work environment. And if you look at actually the research, this is the light that you should work under for psychological reasons and otherwise. But definitely the benefit is having that daylight. The other one is that increasingly LED panels now able, you know, to be put in instead of fluoros, because the panels last forever and fluoros obviously do break in time. So if you're in a position that you're in a practice where they're putting in new lighting, just make sure they've got LED panels that also have a switch on them, because the LED panels actually have a switch on the side and you can pick what color it is. You want to make sure that it has a daylight color attached to it, and that's quite important. The other important part is to move your examination bed away from the wall. Most practices will have, you know, the doctor's desk and the chairs and everything else, and then the bed will be shoved up against the wall. And as you can appreciate, it's very hard to go around a patient to do a skin check if your bed is against the wall. Now, this is a photograph of our practice at Redcliffe. And as you can see here, the bed is against the wall, but the head is against the wall. And the benefit is of course, is that the doctor can walk around the patient when they're doing a skin check. Whereas obviously if the bed was against the wall, they would actually only be technically be able to see half of the patient and then would have to roll them over and roll them over again. So if you do have the space, and I obviously accept that every room is different and some rooms are small and some have space, but if you do have the space to just shift it out, you know, a couple of feet, whatever, just enough space for you to be able to get around it will make a very, very large difference in your ability to be able to conduct a thorough skin check. Once again, optimizing your time, because you don't have to keep, once again, turning the patient over to do that. The other one is around the right tools. So once again, we only need a small number of tools. So we have loupes or magnification, and there's also a product called Lumio, which is like a handheld magnifying, 2x magnifying device with some LED lights, or loupes. We need a dermatoscope. I mean, the fact of the matter is you cannot diagnose skin cancer without a dermatoscope. You should also learn how to use that dermatoscope and, you know, get some training on it. But it's a very, very simple tool to use. And also, once again, the education or training to use it is also not that difficult. The other one is image capture. Now, it's not important that you're able to take photos, but it is something which which I could recommend you do. Most clinical notes packages will allow you to import images fairly easily. We use them for before and after procedures. But once again, I mean, the image capture could just be as simple as just a standard little camera. You could use your phone, but just be mindful of, you know, patient data on your phone. You do need to delete it off your phone once you've transferred it. And also, a lot of dermatoscopes nowadays, they've got these click-on attachments, so you can attach it to a smartphone or attach it to a camera very, very easily. And a lot of them are magnetic, so it's actually just very easy to pull it on and off. So just as far as examination tools are concerned, these are the sort of loupes here on the left, which, you know, most practices have. I mean, they're actually designed more for needlework, but they're, you know, probably not that comfortable to wear, but at least you do have magnification. The ones here on the right are obviously something which is going to be more calibrated to your head and also to your eyesight. And you can also see this one here as a light on the end of it, which can be very handy when you're doing a skin check and try and look inside someone's ear or around, you know, those sorts of areas, which obviously clearly the light from the roof may not be good enough. Now, I think that the key thing is that with these sorts of tools, the same with the dermatoscope, you really only need to buy them once and then, you know, have them for the rest of, well, for many, many, many years into the future until you decide that you want to change that. The other tool to have is a dermatoscope. As I said, it's impossible to diagnose skin cancer with the naked eye, not completely impossible, but all the research shows that obviously you're going to be far more accurate. It also is very impressive for the patient that when they come into your practice and they say, hey, doctor, what's this thing on my arm? And then you pick up your dermatoscope and put your dermatoscope on it, the patient feels like they've actually had a thorough examination of that suspicious lesion. Also, when you look at the image in the dermatoscope, you're going to have all of this other visual information, so asymmetry and border and color and all these other features which you can't see with the naked eye. So, in our country, I would argue a dermatoscope is as important as a stethoscope. The other thing to note with a dermatoscope is don't just have one in the practice, because what you want is this dermatoscope to be on your desk and be able to use it all the time when patients come in. Now, whilst we're going to talk about in a moment about getting patients to come in for skin checks and how we could manage that as a process, the fact is you're going to have patients coming in the door every day that have suspicious lesions on them. They might take their shirt off for some other reason, or you might pick something up that's unusual on their body. To have that dermatoscope on your desk and be able to pick that up and put it straight onto it, you will pick up skin cancers that the patient didn't come in for, and you will find melanomas, and you will save people's lives. So get a dermatoscope. The good thing about them is that, you buy them and you can have it for, 5-10 years. The fact is these things don't need calibration. They do vary, and just to give you a bit of an insight, this is here as a DL100, just to give you an example. So a company that makes 2 different products. This one here needs batteries. This one is rechargeable. This one's got a biggest eye area and attaches to a camera. This one doesn't. This is why this product is obviously a bit more expensive than this one. But the fact is that get something that gives you that 10 times magnification and light, because that is critical in the diagnosis of skin cancer. But as I said, make sure you buy your own. The other element is that you want to have a punch or shave setup. So inevitably what's going to happen is you're going to have patients come in, now whether that's for a skin check and they've booked the skin check to see you, or they happen to be there for another reason and you find something that's suspicious. Now, one of the great advantages of having a biopsy set up in your room, and we don't need much, and I'll show you a picture of one from our practice, is that you can sit there and go, okay, patient, you said this thing's got a history of change or this lesion. I agree with you. I think it's something we should take a biopsy of. You're then able to then just turn around, pick up the tools you need to then obviously infiltrate and then do the biopsy and send the patient away knowing that you have collected the histopathological sample to give us a diagnosis. Some practices talk about, doing the skin check or associated and then bring the patient back, later in the week or next week to do the biopsy. I would absolutely caution you not to do that, because the key risk is the patient doesn't come back, right? So we've now sent someone out the door with something we're concerned about, but yet we actually haven't taken that opportunity whilst we had the patient there to take that biopsy. If you learn how to do a punch or a shave properly and you get the right training for it, it should take minutes. And the other advantage now is in that consultation, which could be a 23 or a 36, whatever happens to be, you now get to bill for the consultation and the biopsy. So it's now a 23 and a 30071. So obviously the use of your time and the reward for it is far greater, but more importantly, we've taken action on something which we're concerned about or the patient is concerned about. Definitely having a cryo flask. Cryotherapy is something which we do use regularly. Obviously you need to use it appropriately, but having a cryo flask on your desk when you are doing skin checks is also very, very useful. And the other thing to have is, patient information brochures, and every other thing. So when we, let's say, look at non-surgical methods, so if we want to, let's say, use Epidex or a product like that, giving the patient information so they can see what's going to go on, because there is obviously a period where they're probably not looking their best, will be very, very helpful for you in your practice. So once again, cryo flask, very essential tool. And as I said, we've trained our staff to fill them up before the beginning of every session and be very careful with them. So don't dent them, because otherwise they freeze up. This is a biopsy setup. You know, if you looked at that practice I showed you before where the bed is, the bed would be sitting right here. And then we got the biopsy set up and the cryo flask sitting straight next to the bed. Now, you may not have the luxury of a trolley in your room. You can just put it on a bench or a table. And effectively, you just need some insulin needles, some local anesthetic, and some punch and shaves. And look, the key thing is that punches and shaves, you can get them supplied by a pathology company. They don't cost you anything. You can use them as an excision tool. So if you had something that was small, you could take a punch and take the whole thing out, and that would count as an excision. Once again, with the appropriate margins, so depending on what that lesion is. And you can also get shave biopsies as well. So, you know, increasingly shave biopsies are being used, need to be used appropriately, of course. And, you know, obviously we're talking about particular sorts of lesions, but it is once again quite a simple skill, and the dermatologists do use it very, very regularly. The advantage of the shaves is you don't need sutures, and I'd argue in small biopsies, punch biopsies, you don't need sutures either. Now, setting up your appointment book. So this is assuming, once again, that you're wanting to do your skin checks in a session, in a block. So what we've typically found in the past, if you've developed the skills to do skin checks and you start doing skin checks on your patients, what happens is those patients will come back for an annual skin check. If you've had a, let's say, diagnosed a BCC or something on them, they might come back every 6 months. If you've diagnosed a melanoma, it might be every 3, 6, 9, 12, right, depending on what the lesion is. And, you know, we teach that and very happy to show that to you. But I think the key thing is, if you're going to set your appointment book to do skin checks, effectively it's broken up into 3 parts: skin checks and results. So what we're saying is, in our consultation room, we want to allow the appropriate time, and that's typically about 15 minutes. Now, it could be 20, it could be a new patient, and you need to learn more about their personal or family history. But effectively, you know, a skin check is a 15 or 20-minute process. And also, if we wanted to deliver results, we can fit those results into this consultation session. The other element, of course, is if we do skin checks and biopsies, we then typically will then end up leading to surgery. So we need to create surgical sessions. So my advice, if you're going to start doing routine skin checks and biopsies, and from those skin checks and biopsies come surgery, is to put those surgical cases in a block, because it's much more efficient for your time to be doing procedure than going from one room to another and back to another. Definitely from our experience, that's far more efficient. The other thing to note is that surgical cases are not based on time, right? So whereas consultations, they're time-based, biopsies are not time-based, and procedures are not time-based. So if you can be more efficient, it doesn't change the item numbers that you'll be billing for those sorts of procedures, and hence why I'd suggest you do them in an efficient block. The other element, of course, is that if you're then going to inflict a wound on a patient, there's going to be some level of wound management and then removal of sutures at the end. Now, my recommendation in that is to get that done by your nurse. If you've got a practice nurse, get them to manage it, because you can't bill for it. And for me, it's a case of, if you can't bill for it, you probably shouldn't do it. I'm not saying you shouldn't come back and see the results of your handiwork and give the patient the results, and once again, see obviously how they are and talk to them about what follow-up there is. But the physical need to change dressings or take out sutures really should be done by a nurse. Now, talking about the services you should be able to provide. So as a GP in Australia, I'm very clear on this, that I think that these are services you should be able to provide. You should be able to provide a comprehensive, full head-to-toe skin check to a patient in 15 minutes or so. Now, that will vary, of course. You've got someone who comes in with one thing to look at. That's obviously going to be much shorter. You get somebody who takes off their shirt and they're a DNS patient, so a dysplastic Levi syndrome patient. They could have 100 things that might need to be considered. So it's not necessarily one size fits all, but I'm just conscious of the fact you should have the confidence to get a patient undressed and be able to do a systematic exam from the top of their head to the toes, turn them over and back again within an appropriate time, and then know what you're looking for, so you can put your dermatoscope on those ugly ducklings or those unusual things, so you can assess them for whether they need to be able to have biopsies done. You need to be able to have the skills to be able to do a punch or shave, and at the time of consultation. So a lot of that comes down to the right tools and the confidence and the skills to be able to do a biopsy, as I said, in a relatively short period of time. I mean, it should take seriously minutes to do one of those. The other thing that you should also be able to do is an excisional biopsy. So an excisional biopsy is something that we would use for a suspected melanoma. Now, melanoma is 4% of the cancers that we will treat. So this is not something we're going to do all day, every day, but you should be able to do it. Now, the importance of being able to do these particular actions is we will get a diagnosis, right? We will know what that lesion is on the body, and then you can make the decision as to whether you're confident to treat it, whether you need to refer to it in somebody within your practice who may be, once again, a little bit more confident in managing skin cancer, or refer it onwards. But at least at this point in time, we've got a diagnosis for that patient versus we're just going to refer them out to a specialist or somebody else having no idea what it is. And I think that, at least then if we know it's a melanoma and you're not confident to treat it, we would obviously escalate that case and make sure that patient is seen quite quickly. One of the challenges we have in Australia is when you refer to specialists or to the public hospital, the waiting times can be quite long. I mean, particularly the public hospital case, you could wait over a year to be seen. If you know that's a melanoma, you can obviously pick up the phone and make sure that patient is seen in a quick time, because we don't want people dying unnecessarily sitting on waiting lists. The other skill that you should be able to do is to be able to do elliptical excisions on non-cosmetically sensitive areas. So areas like the back and places like that. If you look at melanoma, the vast majority of melanoma, just using it as one example, as a cancer, more than 50% of the distribution is on the trunk of a male, right? So if you don't take off their shirt, you're not going to see them. And secondarily, a lot of these cancers can be treated because they are, once again, a non-cosmetically sensitive area. With females, it's the trunk and the top of their legs. So, I'm just conscious of the fact you should be able to do basic elliptical excisions in non-cosmetically sensitive areas. Learn the skills of peridermal suturing, so you can take the tension off the wound, so you get good scars, etc. And these, once again, are all skills that you can very easily learn and be able to apply them in your practice. So the skills that you must have if you are going to manage skin cancer in your practice. You need to learn dermoscopy, but not just pick up a dermatoscope. You need to learn an algorithm. So you need to learn a methodology of when I put the scope on the lesion, I'm trying to score it, or typically scoring it is the term we would use, to work out whether it has X many features which lead us to a diagnosis, this lesion is suspicious, or once again, we may know what that particular cancer is. The great thing about dermoscopy at the very basic level, you'll learn benign, suspicious. So leave it alone, do something. As you learn more advanced dermoscopy, you'll learn pattern recognition, which means you'll be able to pick what the cancer is, because obviously all cancers, or most cancers, have specific features. And once again, they are skills that are quite easily learned and developed over time. The other one, obviously, is learning how to do a biopsy, but you need to understand which biopsy and where to use it. So in other words, if I'm taking a punch, which part of the lesion am I punching, right? Because you can't punch the whole lesion if it's a big lesion. And also, as I know, where I should be using a shave biopsy versus a punch biopsy. So it's not just can I do a biopsy, do I actually know how to do the best biopsy possible to get the pathologist the best sample to get obviously the best diagnosis that we can. The other one, once again, is to perform excisional biopsies, as I touched on before. And typically that's, an excision with a 2 millimeter margin so that we can get a diagnosis. If it does come back as a melanoma and you're not comfortable to do the wider excision, you can refer them on, but at least now we've got the diagnosis and we know that that patient needs to be seen quickly. The other one is, as I said, to learn how to do surgical excisions. And if you're not comfortable doing surgical excisions, which many doctors aren't, and that's nothing wrong with that at all, is basically have a trusted source of where you can refer those patients to. So it might be, once again, a doctor in your practice who's interested in doing skin cancer, or it could be, once again, to another clinic, like a primary care clinic with a skin cancer doctor who's happy to do those more complex procedures, or to a specialist. So I think the key thing is, just have in your mind that if I can't do it, who am I sending it to, that I, once again, have trust and confidence, and may understand, what the cost or the time wait for the patient is, and take that into some consideration. The next thing to do is, once again, is we want to be looking at skin checks or doing skin checks on people that need a skin check, right? Not people who don't need a skin check. I mean, whilst skin cancer is the most common killer, or one of the most common killers of young people, that's because they typically don't die of other things. if you look at the incidence in skin cancer, once you hit 50, it just skyrockets up. So typically the older groups is what we're looking for. And the key thing for me is that there are patients walking in your door every day who have skin cancers on them that are not even aware of it. So one thing is that once you've upskilled and, you know, you have that confidence and you've got that piece of paper on the wall saying, I've got, you know, skin cancer skills, you know, let your patients know, because many patients would get a skin check with you if they knew that you did it. You know, traditionally, as you know, in the past, it's been, I had to go to my GP refers me to a dermatologist, you know, I have to wait. And there could be convenience or cost as barriers to people getting their skin checked. Whereas if they knew you as their family doctor, somebody who they know and trust, could obviously do that. But I'm just conscious, as I said before, you are going to pick up cancers on patients, just incidental findings, because they are in your practice and they're there for another reason. The other thing is that we want to make sure that we understand our patients. So for example, a patient with a family history or a personal history of melanoma is a high-risk patient, right? So if you actually knew that your patient did have that history, you would be seeing them and encouraging them to have skin checks on a more regular basis than clearly somebody who's got no family history. So understanding and asking those questions definitely is very useful. Also their work environment. I mean, if they're outdoor workers, I mean, as you know, most people don't put on sunscreen and wear proper sun protection, etc. So if they are exposed to lots of ultraviolet radiation, they also could be exposed to chemicals. So people that work on, you know, roads and highways are exposed to chemicals, which also are not very helpful. And finally, you know, leisure activities. I mean, if they go out and go fishing all weekend, same thing. They're obviously getting exposed to way over the normal dose of ultraviolet radiation. And, you know, we need to be mindful of that. And I think the key thing is if you identify, you know, patients, and they're typically 50 plus, Caucasians, right? Males typically are a higher incidence level, but males typically are a bit lazy when it comes to being proactive with their health. So sometimes having their wife or partner involved is definitely very helpful. But, you know, effectively you can ask your patient, you know, if you've got someone who's a 65-year-old Caucasian, clearly with sun-damaged skin, I mean, there's nothing wrong with saying to them, say, hey, Bob, when was the last time you got your skin checked? You know, you're in a high-risk group, don't really want you to die from skin cancer. And if the patient then wants to get their skin checked, that's well and good. I mean, we don't have to force people to do it, but for the most part, you know, people are busy in their lives, right? They're not thinking about these things on a daily basis. So unless you bring it up with them, you know, suggest it or otherwise, they're not going to take that affirmative action. So once again, just understand that all of the patients you'll ever want to treat are already coming in your door. You just need to have a conversation and make them aware of it. Now, the importance of learning all of these skills and having your room set up and everything else is the fact that you will make a difference. Now, what I mean by that is this. By providing patients access to skin checks, you will find skin cancers, right? You will. There is no doubt whatsoever. And most importantly, you are going to find melanomas the patient was not aware of, and you are going to save their life, right? I mean, imagine the impact of that. You found a melanoma on a patient, they did not know it was there, you probably have saved their life. The fact is the patients will be very, very, very grateful, right? They will probably send you thank you cards, give you Christmas gifts, and tell all their friends how awesome you are as a doctor because you've just saved their life. Now, ultimately, there are SCCs and BCCs, which obviously are less life-threatening. I mean, SCC, bear in mind, is still a third of all deaths in Australia, so it's not insignificant as far as its you know, risk to the patient. But the fact is the patients will be eternally grateful for you, and then they will come back and get their skin checked and once again be very happy for that service. And the other great thing about learning these skills and providing these services, it's one of the very few areas in general practice where you control the entire process. Now, not obviously every patient, you know, an advanced melanoma is not something you're going to manage, but if you consider that melanoma is only 4% and BCC is obviously over 70%, we're in a situation that from initial presentation, so turning up to you through to biopsy, through to treatment, and that could be non-surgical or surgical, but definitive treatment, you can control the entire process. As you know, unfortunately, sometimes in general practice, you're going to come across cases and then you have to refer them on. And you've probably got, you know, you get a letter back, but obviously you're not in control of the process. You have to rely on the patient to turn up. There's a whole bunch of other mitigating factors where, but in skin cancer, you can actually control it from beginning to end. And that's unique. And I think that's once again an important aspect to consider as you look at, once again, offering these services to your patients. And I think that the key thing also is that a lot of people look at skin cancer and go, this is a scary area. Now, yes, if you get it wrong, if you misdiagnose, but not necessarily misdiagnose, if you miss. So patient comes in, shows you a cancer, you go, oh, that looks fine, come back and see me in 6 months. But that turns out to be a melanoma. That's obviously not a good thing. The fact is that it's very, very simple to learn the skills to how to be able to diagnose. So how to use a dermatoscope and use a very simple algorithm to diagnose, how to do a punch or a shave, very simple skill to develop, and then be able to do simple elliptical excisions or, incisional biopsies or elliptical excisions is also a very, very simple skill to learn. And once again, once you've learned these skills, you now have confidence in what you're doing. So it moves away from, when in doubt, cut it out. I've got no idea. Let's just not leave it on the patient. When you develop these skills, your diagnostic accuracy and the ability to help your patients will be immensely changed. And these are skills for life. Once you've got them, they just get better and better and better. And then you'll be able to help your patients from now and for the years to come. And that concludes my presentation, and would like to take any questions.
Thank you, Paul. We actually only have one question at the moment, but quite a few people are on the webinar, so please feel free. It's the questions panel inside the GoToWebinar little dashboard. You'll find a little word questions. Click on the down arrow on the left side. We do have one question just to get everyone started while everyone's thinking of their own questions. It's from Dr. Keith Bonington. It was around the image capture. He said, I would have thought image capture was essential.
Yeah, I think, so Keith, hello. And look, I don't disagree with you. I think that ultimately what I'm really looking at, I suppose, as far as this presentation, is looking at, generalist GPs getting started in skin cancer. So, I think from my mind is that, the essential tools and skills are around having a dermatoscope and knowing how to use it. That's the number one skill that I think every GP in Australia or in New Zealand and anywhere in the world that obviously has such a high level of skin cancer should have. So I think that for me, it's a case of have the dermatoscope, have the algorithm, and then I think the next step definitely is image capture. In our practices, we do have image capture, but we're doing skin cancer all day, every day. I'm just conscious of, many of the doctors probably on this call are just doing the occasional skin check and may not feel comfortable in, I suppose, making the investment or understanding that systems and process. I'd be very happy in a future webinar to go into imaging in depth and show how it can be done very simply all the way through to, in a fairly complex environment. But I do agree image capture is very useful. I think though, for my mind, is that we traditionally would caution against monitoring things you're concerned about only because of the risk the patient may not come back. So if I've got that such a high degree of concern that the cancer and or the patient does, I'd definitely much prefer, I think, we would recommend doctors take action now versus saying, well, let's take an image and come back in 3 months' time and we'll see if it's changed. If it's in a cosmetically sensitive area, that's definitely the right way to do it. There's no doubt at all. But there is research obviously around the fact, the challenge is around obviously making sure patients do come back for further monitoring. But I agree, and I think that also imaging has gone from big SLR cameras and very expensive and very difficult now to being attachments to smartphones. So that's only going to get better and better and quicker and easier to use. And I also think that in the future, doctors will take lots more photos of everything, right? There's been a level of resistance of taking images for fear they'll end up in a court somewhere in a medico-legal case. The evidence is to show that's not the case at all. And ultimately, images are going to help you a lot as a doctor, particularly if you've taken an image of a lesion and then you get the diagnosis back, from the biopsy or the surgery, that'll help you correlate and learn from that process. So totally agree that I think imaging is important, but I think at a very basic level, much more important to have a dermatoscope and learn how to use it.
All right, excellent. Thanks, Paul. Very detailed. All right, now we have a range of questions coming in, which is good. I'll sort of try and group them together. Some are a little more billing related, and then some were general. So, can you do and build 2 or more punch biopsies in one consult?
Yeah. So the answer is yes, you can. when you do procedures in Australia, it's subject to the multiple op rule. So in other words, you get 100% for the first biopsy, you get 50% of the Medicare schedule for the second biopsy, and then 25% for the third. So the answer is you could do multiple biopsies on a patient. I mean, I'd suggest you don't need to do 10 on a patient. That would not be very good. But the fact is that you can do multiple biopsies. It's just subject to the multiple op rule. And I think that once again, definitely using biopsy as a diagnostic tool versus just cutting things out, definitely it would be a good way to go. But yes, that's the way it's applied in Australia as far as how it's billed.
Excellent, thank you. And if a patient has 4 to 5 actinic keratosis, do we have any billing for it, or is it just time-based?
So AKs, I'll be honest in saying not my area of expertise. I do know it, but the schedule's changed last year. So there is actually a separate presentation, which actually is on our webinar blog. So if you actually look up Medicare presentation, we actually have a complete presentation on all the skin cancer item numbers and how they're applied. So that would be the best resource to go to.
Thank you. Many thanks, Paul. It's not a question. What's your favorite brand / type of dermatoscope?
Yeah, I think this is it's a personal taste. It's a bit like saying, do we want to drive a Mercedes or a BMW? It's really, they're both cars. Look, there's 2 major manufacturers of dermatoscopes, to be honest. There's Heine, who basically invented it. In fact, it's the 30-year anniversary of the dermatoscope this year. They developed the technology based out of Germany. And then the other company that produced is a company called 3Gen, based out of California. Look, they're both different tools. The Heine is German, made of stainless steel. Definitely, it's the big handheld thing I showed you. The 3Gen products tend to be a combination of small, big, and have a bit more of a variety of range. It's really about personal preference, to be honest. It's what's comfortable in your hands. So definitely, if you go to an event or somewhere and they've got trade stands and you can then play with the different things. The fact is, it's 10 times magnification with light, now LEDs, and then there's polarized and cross-polarized light. So obviously, as you get a higher quality or slightly more expensive product, as I said, it'll have a bigger iris, might attach to a camera where the other one doesn't. But the key thing, I think, with all this sort of stuff, and it's with certain tools, buy a good quality one that you like, because sometimes when you sit there and say, well, I'll buy the cheaper one because, that's what I'm doing, isn't always the best situation. Because if you consider it, for the most part, most of the people on this call will be paying 50% tax. So let's say you save $200, $300, $400. Well, $200 that you're going to be paying to the tax office. So my general recommendation is find something you like, because you will use it for the next, 5, 10 years. So be comfortable in your hand. And I think definitely having something that's rechargeable that sits on your desk in a cradle is definitely a much better tool for you to be able to use on a daily basis.
Excellent, thank you. This question, it just says for cryotherapy. I'm not sure, might have got chopped off. We might just wait. Doctor, if you've got a question on cryotherapy, if you could just elaborate. Yep. The next one we've got, do you find time management is easier in skin cancer work due to more predictability than standard general practice?
Absolutely. That's one of the beauties of integrating skin cancer inside your general practice. So the good thing about, when you've got patients booked in a block, so I didn't really go into detail. It's one of the things we teach in the skin cancer medicine course, actually how to set up your appointment book, because it is a bit more of a wider discussion, but just in a broad sense. What the best thing to do is to say, put all my skin checks in a block, because once you start developing these skills, you start doing skin checks, patients come back for, 3, 6 annual month reviews, etc. You put them in a block. So skin check, skin check, skin check. So let's say Tuesday morning, I'm doing skin check. Because of skin check, I know what's involved. Come in, get undressed, assess the skin, do biopsy, yes or no. You can do that one after the other. So the beautiful thing about it is you can basically run on time, because, there will be the occasional patient that'll be shorter and occasional patient longer. But the challenge you've got in general practice, you've got no idea what the patient is turning up for. Even though they've got a standard consultation time, they might be there for a repeat script, or they might be there for something that's going to take you 35 or 45 minutes. So it's very, very hard to time manage. in general practice because you've got no idea what's coming through the door. Whereas if I put all my skin checks in a block and also I put all my procedures in a block, I'm in control of those times. The other benefit from doing them in those blocks is that when a patient rings up and says, I'd like to book a skin check with Dr. Bob, they know it's Tuesday morning is where they should be placing a patient into your skin check session. And we've seen over the years that people develop, you know, those sessions grow and grow and grow, and obviously they start small and then they get bigger and bigger because you've got more recurrent patients coming in. The patients that have seen you and had a great service tell their friends. You can imagine if you found a melanoma on a patient, they will go tell all their family and friends to go and see you to get their skin checked. So that'll just see your practice in skin cancer grow over time.
Excellent. All right. That's apart from our question on cryotherapy, which is just for cryotherapy.
Yeah.
And
if it's clinical, I won't be the best person to answer it. So my obviously area of expertise is effectively running practices and the education side.
All right. Well, thank you, Paul. Just relating back to that other question about what's the best next steps for someone in general practice who wanted to move into skin cancer. I know we have a new format for the professional certificate in skin cancer medicine. If you just give us a bit of information on that, we'll finish.
Yeah, I think once again, as I said before, I mean, as a doctor in Australia, you know, having the basic skills of dermoscopy, or how to do a skin check, dermoscopy, or how to take a history, how to do a punch and a shave, what the most common cancers are, how to non-surgically manage, obviously some of these lesions, and then how to surgically manage for them, how to bill for it, and then how to run the workflow process. I mean, that presentation is like just a small summary of a presentation we have. We've actually changed the structure of the Certificate in Skin Cancer Medicine course into a one-day practical workshop, then with basically a day of content which is online, so you can do that at your leisure. Because we're just conscious, we've been running the courses for 13 years and we've had over 6,500 doctors go through that course. But the key thing was obviously it's a weekend and doctors lose a weekend. So what we've now done is done it as a one-day practical course with online. The advantage of that, it's allowed us to reduce the cost of the course quite significantly, and secondarily, it gives the doctors the opportunity to pick a Saturday or a Sunday as the, you know, depending on, once again, kids' sport arrangements or whatever happens to be, but only losing one day of your weekend to obtain those particular skills. So, you know, if you're interested in learning more about it, if you just go to the HealthCert.com website, you'll get those details. We're launching it for the first time in Melbourne in February. But there's also an online version of that program too, but definitely coming and do the one-day face-to-face. You're going to get the practical skills of practicing punches and shaves and barrel dermal suturing and doing procedures, which will be of great benefit to you and your patients.
Excellent. Thank you, Paul. Well, thank you everyone for attending. As I mentioned, this webinar will be recorded, and everyone who was signed up for the webinar will receive a link to watch it. Please feel free to share that with any colleagues who might be of interest, and keep an eye out for your inbox for our next scheduled webinar sometime in the next 30 days. Thank you again, Paul, and thank you for joining us.
Thank you very much, everybody. Thanks for your time. Have a great day.